So next we are going to see the surgical infections in liver. I'm not going to discuss hepatitis B and all. I'm going to discuss surgical infections in the liver, like pyogenic liver abscess. I'm going to discuss 3 infections only: pyogenic liver abscess, amoebic liver abscess, and hydatid cyst. Hydatid cyst of the liver. So these are the 3 things I'm going to discuss now. Let me start my discussion from the roots of infection. Roots of infection to liver. The roots of infection to liver. So the roots of infection to the liver are the following. Just see the image I'm drawing. So this is liver. So through what are the routes the liver can get infected? You can easily understand from this picture. This is biliary route. This is hepatic artery route. This is portal vein route. This is through portal vein route. And this is direct spread or trauma. So trauma, direct spread from adjacent infection somewhere, any diverticulitis or some other direct infection from the nearby bowel. So these are all not important. What is more important is these 3. So the most common route of infection is this route, that is known as biliary route. Biliary route, the most common route of infection to the liver is through biliary route, and it is usually due to ascending cholangitis. It is usually following a ascending cholangitis due to bile duct obstruction. So biliary route is the most common route of infection to the liver. It is usually following a ascending cholangitis. And what is the most common organism which is infected? You all very well know. It is E. coli in the world and Klebsiella in Asia. World level it is E. coli, and in Asians it is Klebsiella. Asians Klebsiella, world level it is E. coli. So the biliary route is the most common route of infection to liver. An interesting point is when it is through biliary route, it will be a multiple macro abscess. Please remember, the abscess will be multiple macro abscess. So the abscess will be multiple macro abscess will be seen. If it is through biliary route, the abscess will be multiple macro abscess. So please don't forget biliary route. And apart from this, it will be multi-organism. It will not be only one organism like E. coli or Klebsiella. There will be many organisms isolated from the pus. So please remember, the pyogenic, the most common route of infection is biliary route. It is mainly by ascending cholangitis. The most common organism isolated is E. coli and Klebsiella. But the point is, it is usually multi-organism, biliary route. It is usually multi-organism in biliary route. And coming to hepatic artery route. Hepatic artery route. Can you tell me what is the reason why there is hepatic artery route of infection? So it is a systemic infection. There is a septicemia or bacteremia. So that carries blood. Like for a patient who is having septicemia or bacteremia, the infection is carried through the systemic circulation to the liver. So this is multiple micro abscess seen. Multiple micro abscess is seen in these cases. And it is usually single organism. It is usually single organism. The most common organism is Staphylococcus. The most common organism causing infection through hepatic artery route is Staphylococcus. And portal vein route, it is usually through the superior mesenteric vein. It is through a superior mesenteric vein which carries the infection from appendicitis, diverticulitis, or any infection in the colon is brought to the liver by this portal vein route. Usually follows appendicitis, diverticulitis, or any other infection. Diverticulitis or appendicitis, the infection, pylophlebitis, all these things can carry infection through the portal vein and causes infection in the liver. And please don't forget, the infection amoeba is also through portal route. So pyogenic abscess can spread by 5 route: trauma, direct spread, biliary route, hepatic artery route, and portal vein route. But entamoeba histolytica causing amoebic abscess is only via portal vein route. It's only via portal vein route. Please don't forget this point in this exam. So now let us discuss what happens to 2 patients. One patient coming to you with a pyogenic abscess. One patient coming to you with a pyogenic abscess. Pyogenic liver abscess. Another patient coming to you with a amoebic liver abscess. So let us see the various points, differences between these 2 guys. So pyogenic and amoebic liver abscess. Who will be very sick on presentation? Can you tell me who will be very sick on presentation? This pyogenic abscess patient will have fever, chills, rigor, with hepatomegaly. That is the presentation this patient comes to you. He will be very sick patient. So pyogenic abscess patients will be very sick, and they will have severe right upper quadrant tenderness, and male to female ratio is 1.5:1. It's around equal. It is nearly equal. Male to female is 1.5:1. Whereas this amoebic abscess comes to you with only hepatomegaly. Mainly they have hepatomegaly and pain. Pain is the most common symptom, and hepatomegaly may be there. Pain and hepatomegaly are the features of amoebic abscess. Whereas pyogenic abscess will have fever with chills and rigor. An interesting point is it is very common among males, and it is very rare among females. Especially it is totally absent in menstruating females. So menstruating females, amoebic abscess is not seen. Don't know the exact reason, but iron deficiency anemia is protective. Please remember what is protective of amoebic abscess means. Iron deficiency anemia. It's a new interesting point. Iron deficiency anemia, if you have, you will never develop amoebic liver abscess. This is very common in these females with the menstruating females. So iron deficiency anemia is protective, and menstruating woman will not get amoebic abscess. Menstruating female will not get amoebic abscess. Okay. So now when you do lab investigations for these guys, so before that, let us see what are the predisposing factors. Who will get these abscess? Predisposing factors are, so this pyogenic abscess is more common in immunocompromised people. So whenever a patient comes to you with a pyogenic abscess, please rule out immunocompromised state like HIV, diabetes mellitus, or any other immunocompromised state is a predisposing factor for pyogenic abscess. There is only one predisposing factor for amoebic abscess, that is alcohol. Alcohol is a very important predisposing factor for amoebic abscess. Okay. And when they come to you, we do lab values. So lab values, there will be increased LFT. LFT will be increased, especially there will be increased alkaline phosphatase, and there will be increased bilirubin in case of pyogenic abscess. Pyogenic abscess, LFT will be increased, alkaline phosphatase increased, bilirubin will be increased. But in case of amoebic abscess, everything will be normal. And there is a super specialty question from direct line from Sabiston. Please don't forget there is only one value which is increased, that is increased prothrombin time may be seen. So the only liver function abnormality seen in amoebic liver abscess is elevated prothrombin time. The only liver function abnormality seen is elevated prothrombin time. Please don't forget. So but there is altered liver lab values in case of pyogenic abscess. When you do serology, serology is positive for amoebic antigen. For amoebic antigen, entamoeba histolytica antigen, this is positive, and it is negative in pyogenic abscess. When you do blood culture, who will be more blood culture sensitivity, which will be more positive? So blood culture sensitivity is positive in case of pyogenic abscess. It is negative in Amoebic abscess. So please remember I'm telling you the differences between these two guys. So pyogenic abscess will have fever, chills and rigors. It is around equal in male and female. But amoebic abscess is more common exclusively in males. Females, I have also not seen a pyogenic abscess so far. Amoebic abscess in females so far. So predisposed by immunocompromised patient, it is predisposed by alcohol. There is altered LFT seen in pyogenic abscess. It is only prothrombin elevation in amoebic abscess. Serology is positive in amoebic abscess. Blood culture positive in pyogenic abscess. Then how to differentiate these two? We have to take CT scan. One of the best methods to differentiate between pyogenic and amoebic abscess is pyogenic abscess will have clustered abscess like this. The abscess will be clustered like this in the liver with a peripheral rim enhancement will be there. It will not have a well-defined border. It will have a clustered abscess with a peripheral rim enhancement seen. Peripheral rim enhancement is seen and there is a clustered abscess on CT scan. This guy will have a well-defined abscess. Well-defined abscess with no peripheral enhancement, but there will be peripheral wall edema. There will be peripheral wall edema. So please remember the tropocytes are not present inside the abscess. They are present in the wall. So trophocytes are present in the wall. It is not present inside the abscess. So the abscess will be very well-defined hypodense lesion. Well-defined hypodense lesion with a peripheral wall edema is present here. Here it is clustered abscess with an ill-defined clustered abscess with the peripheral rim enhancement is seen. Okay, with the peripheral rim enhancement is seen. And please remember this is 50-50, 50% multiple, 50% solitary. But amoebic abscess is mostly solitary. Amoebic abscess is mostly solitary and it is most common in segment 7. So where is amoebic abscess common means it is common in segment 7. Okay, it is common in posterior, right posterior lobe. Right posterior lobe, it is most common in segment 7. So these are all some findings which helps you to diagnose it as amoebic abscess. It has peripheral wall edema, it is usually solitary, it is most common in segment 7. Whereas this will have clustered abscess and 50-50 time it is multiple. It is 50-50% time, it is multiple in pyogenic abscess. So now let us discuss pyogenic abscess. Pyogenic liver abscess, what will you do? So pyogenic liver abscess patient is very sick and toxic. Therefore, no other way we have to treat them immediately. Otherwise, they will go for many complications. What are the complications of pyogenic liver abscess? They will develop sepsis. So please remember they will develop sepsis. They will develop endogenous endophthalmitis and blindness. Endogenous endophthalmitis is seen in 3% cases of Klebsiella infection. 3% cases of Klebsiella will develop endogenous endophthalmitis and they become blind. They may develop osteomyelitis. They may develop infection of the heart. So they can develop infective endocarditis. All these are due to spreading of the bacteria in the blood circulation. So therefore, pyogenic liver abscess, the treatment is immediately we have to aspirate. Aspiration is a must in case of pyogenic liver abscess. Only for multiple micro abscess we don't aspirate. Otherwise, for most of the abscess we do aspiration. Aspiration is a treatment of choice and based on blood culture sensitivity and pus culture sensitivity, we will treat them with higher antibiotics. Higher antibiotics are given for these patients. So please remember aspiration is a treatment of choice for multiple macro abscess. Only for micro abscess we treat by only medical management. If it is a macro abscess, we have to aspirate the abscess. Okay. And coming to amoebic abscess. Amoebic liver abscess, you all know the color of pus. What is the color of pus? The color of pus is anchovy sauce pus. Anchovy sauce pus is the color of this pus. Anchovy sauce pus, the color of it. It is odorless. Interesting point, it is odorless. There is no smell, no bad smell when you aspirate even 1 liter of amoebic abscess, you don't have bad smell. It is odorless. Anchovy sauce pus, it is odorless. And the moment you see amoebic liver abscess, you should know the complications. So please don't forget the following complications. So the most common complication is reactive pleural effusion. Please remember, it is reactive pleural effusion. Because of abscess in the right lobe of the liver, you will get reactive pleural effusion. It doesn't mean there is a rupture. It is only a pleural effusion. Reactive pleural effusion. That is the most common complication. Most common site of rupture. The amoebic abscess can rupture. Where is the common site of rupture? It will usually rupture into peritoneal cavity. No controversy in this. Please don't get confused. It will not rupture into the lung or it will not rupture into the pleura. It will rupture into the peritoneal cavity commonly. The most common complication is a reactive pleural effusion. Most common site of rupture is pleural cavity. Other places it can rupture or it can rupture into pleura. It can rupture into mediastinum. Very rarely mediastinum. Very rarely into the bronchus. So if it ruptures into the bronchus, the patient will have broncho fistula. Bronchial fistula will be there. Because of the fistula, the patient will have on coughing itself, he will have anchovy sauce sputum. Anchovy sauce sputum seen on coughing. So what you should do, these patients, we make them lie in a prone position, we make them lie in a dependent prone position and give them bronchodilators. That's all, that is enough. The pus drains by the mouth. Okay, the pus drains by the mouth. Keep a bronchodilators, keep in a prone position, tap them on the back. All the pus from the liver will come through the communicating bronchus through the mouth. It will come out to the mouth. If it is connected to the pleural cavity will have the amoebic abscess. Such patients we will put only ICD. Intercostal drainage is enough. Mediastinum is very rare. Rupture into mediastinum is very rare. So please remember the most common site of rupture is into the peritoneal cavity. So no need to do anything about the reactive pleural effusion. Usually it resolves after you treat the amoebic abscess. Usually it will resolve. If it is a ruptured into pleura, you should put an ICD. If it ruptures into bronchus, you should take the patient like prone with the bronchodilators. So now, interesting points in amoebic abscess. Amoebic abscess usually follows what infection? Can you tell me? Don't directly attack the liver. It usually follows colonic infection by Entamoeba histolytica. Around 1/3 of the patients will have history of amoebic dysentery. 1/3 will have amoebic dysentery. So remaining 2/3 will have a subclinical infection. Only 1/3 will have amoebic dysentery. 2/3 have subclinical infection. Okay, subclinical infection. And I already told you, menstruating women will not get this infection. Menstruating women are not getting this infection. Iron deficiency is protective. Iron deficiency anemia is protective of this amoebic abscess. Please don't forget these points. So this amoebic infection spreads through portal vein route to the liver and it is usually segment 7, large single abscess. It is usually large single well-defined abscess. The treatment of amoebic abscess is very simple. Just start them on injection metrogyl at a higher dose. Injection metronidazole is started at a higher dose like 750 mg. IV TDS is started. And you give IV injection for 2 weeks. Give IV injection for 2 weeks and then you convert it to oral. And along with this metronidazole, you should also give luminal amoebicides like diloxanide furoate Other amibicide, you will be getting those things in pharmacology, diloxanate, furoate, emetine, all these other drugs are also should be given for at least 10 days to clear the amoeba in the lumen. So diloxanate, furoate, emetine, all these drugs are used for clearing these organisms from the circulation. Please don't forget these points. Okay, so diloxanate, furoate are also given. And now comes the question, when will you aspirate an amoebic abscess? Indication of aspiration of amoebic abscess. Indication of aspiration of amoebic liver abscess. So please remember, number one, the main reason is when you have a doubtful diagnosis. So when you have a doubtful diagnosis, we don't know whether it is amoebic or pyogenic. Better take the risk and go for aspiration. When it is more than 5 centimeter size, when it is more than 5 centimeter size, and it is located on the left lobe superficially, and the patient is not responding for 3 days. 3 days we are giving metronidazole, they should respond excellently. Not responding more than 72 hours, we should aspirate. So doubtful diagnosis, more than 5 centimeter size, left lobe it is located superficially, not responding or some more than 72 hours. These are the places where we must aspirate a amoebic abscess. So nowadays we don't only aspirate, we put a what? If there is an abscess here like this, we don't aspirate, we just put a percutaneous, we put a stent like this, we put a double pigtail stent. DP stent is put under ultrasound guidance nowadays. So this stent is left there for about 2 weeks to 1 month until everything in the cavity comes out. Everything in the cavity comes out also, the cavity will be remaining. The cavity will remain up to 6 months to 9 months also. The cavity on repeat ultrasound, it may be present even for 6 months to 9 months, the residual cavity will be there. It doesn't mean there is an abscess, it is just the cavity which is going to slowly obliterate. Residual cavity will be present for 6 to 9 months. So therefore amoebic abscess is not at all to worry, not at all to be worried, you can easily manage amoebic abscess, it is just like that, a simpler case to manage. So pyogenic abscess, you must worry about pyogenic abscess, it is dangerous. Amoebic abscess, less dangerous, you can manage very casually, So pyogenic abscess, aspirate. Pyogenic abscess, aspirate, amoebic abscess, only injection metronidazole. We give only injection metronidazole, okay? I hope you are clear with these. And next we go to hydatid cyst. Hydatid cyst is caused by the organism Echinococcus granulosus, and there is one more, Echinococcus multilocularis. Echinococcus multilocularis is very rare but very dangerous. Always needs resection of the liver. So now there is no more discussion on it. Multilocularis is also known as malignant hydatid cyst. It is also known as malignant hydatid cyst. It is very rare but very dangerous. So it has to be resected always. So I am not going into that. We go to the commonly seen infection, Echinococcus granulosus, which is nothing but dog tapeworm. So this worm is consumed by the dog. It spreads from the dog, it goes to the feces of the dog. So from the dog, it is coming into the feces, the cyst is coming into the feces, which is eaten by the sheep and goats. They are intermediate host. Sheep and goat are the intermediate host. Dog is a definitive host, sheep and goat are the intermediate host. And again it spreads to the dog like this. So it is spreading between dog and sheep. One day accidentally the man consumes the feces of dog containing the cyst by handling and fondling of the dog. The cyst in the feces of dog enters the man and man becomes a accidental host, also known as end host. It will not spread from one man to another man, it will not spread, but it will end in that man itself. That is why it is known as accidental host or end host. So please remember, dog is a definite host, sheep and goat are intermediate host. So in man, it enters the most common site to the liver. The cyst goes up and opens up in the liver. And it produces hydatid cyst made up of how many walls? So this wall I am drawing is derived from the host tissue itself. What is this? Derived from the host tissue itself is known as ectocyst, also known as pericyst, also known as adventitial layer. So please remember, the cyst wall, ectocyst, pericyst or adventitial layer is derived from the host tissue itself. It is a very thick wall. It is derived from the host itself. Okay, it is derived from the host itself. Then comes the second layer, which is nothing but laminated membrane. That is known as laminated membrane. It is a thin permeable membrane, selectively allows some contents. It is selectively allowing the energy to the daughter cyst seen inside this layer. What is this layer? Energy to this daughter cyst is coming through this laminated membrane, and this layer is known as germinal layer. You should not forget these layers. This will be very helpful for you in microbiology also. So inner germinal layer, middle laminated, MI middle. So middle is laminated layer, germinal layer is inner layer which produces daughter cyst. And it is the most active layer, living layer of the cyst is this. This is a living layer. Germinal layer is a living layer which produces daughter cyst, brood, capsules and scoliosis. All those things are in this layer. You will be reading those things in microbiology. So please remember there are 3 layers. Ectocyst, also known as pericyst, laminated membrane and germinal layer. And now comes the question. So hydatid cyst is most common in liver, followed by second common organ is what? Lung. It is also seen in brain. It is also seen in kidney, and it can be seen in many other places. Now tell me where all ectocyst is absent. What are all organs where ectocyst is not there? Only 2 layers are there. Ectocyst is derived from the thick host tissue, so it is absent in lungs and brain. Please don't forget, lungs and brain, ectocyst is absent. It is present in liver and kidney. It is absent in lungs and brain because lung and brain are soft tissues. They cannot form thick ectocyst. So it is present only in liver and kidney. It is present in liver and kidney only. So now coming to the presentation, the most common presentation is hepatomegaly. So there is no pain also. The major presentation here is hepatomegaly. No pain, no fever. Please remember, hepatomegaly is the main presentation. They may get jaundice. If the hydatid cyst obstructs the bile duct, they may get jaundice. Some daughter cysts obstruct the bile duct and can cause jaundice. Hepatomegaly, jaundice are the 2 important presentations of this cyst. And please don't forget the investigation of choice to diagnose. There are many tests available to diagnose hydatid cyst. Immunoblast is the best answer. If you get an answer, immunoblast assay, that is the best answer to diagnose hydatid in the body. Other investigations are ELISA, electrophoresis, Cassoni's intradermal test. All these are outdated. Cassoni's intradermal test, all these are other investigations. Immunoblast assay is the investigation of choice to diagnose hydatid. But we don't do all these things. We follow the radiological investigation. When we do CT scan, radiologically, CT scan shows the hydatid cyst. CECT is diagnostic. So no, not even we do in practice immunoblast, all these things we don't do practically. So when high prone areas like South India, we get more hydatid cysts. So with CT scan itself, we say this is hydatid cyst. And with CT scan, there is a classification known as Garbi classification. This Garbi classification is now modified as WHO classification. It is now modified as WHO classification. So I wish you all to know this classification. The types are CE1, CE2, CE3, CE4, CE5. These are the 5 types of Garbi or WHO modified classification. So CE1 is a clear unilocular cyst. Simple cyst like this. It's a clear unilocular cyst is CE1. CE2 is honeycombing of cyst. That is honeycombing of cyst. So 2 is honeycombing of cyst, also known as rosette-like appearance. Honeycombing or rosette-like appearance. CE3 is like this. What is this appearance known as? What is this appearance known as? So CE3 is this. What is this appearance? This is known as water lily appearance or water snake appearance. It is known as water lily or water snake appearance. CE4 is partial calcification. Partial calcification. CE5 is full calcification. So CE4 and 5 are dead cyst. They are known as dead cyst. CE4 and 5 are dead cyst. CE1, 2, 3 are living cyst. They are living cyst. CE4 and 5 are dead cyst. For a dead cyst, no treatment needed. Please remember, no treatment needed for a dead cyst. For a dead cyst like this, no treatment needed at all. So now coming to the complications of hydatid cyst. So complications of hydatid cyst, I want you to remember only one complication. What is the most common complication, which is seen in around 30% cases? So interesting. Amoebic abscess, most common site of rupture is peritoneum. What is the most common site of rupture of hydatid cyst? It is into the biliary tree. Please don't forget this. So biliary tree rupture, it will rupture into the biliary tract. Biliary tree ruptures, and therefore the patients will develop jaundice. So 30% of the patients with hydatid cyst will have biliary rupture. Most common complication is biliary rupture. Other complications are infection, secondary infection of the hydatid cyst. Secondary infection of the hydatid cyst is other complication. The most common complication is biliary rupture. The patient with the biliary rupture will come and tell the clinical features, sir, I am having jaundice and I am passing grapes in my motion. They will tell grapes passed in motion. Classical history, the patient will tell passing of grape-like thing in my motion is classically seen in biliary tree rupture. So infection is another complication of hydatid cyst, but that is not the common complication. Common complication is biliary tree rupture. So now coming to the treatment of hydatid cyst. So once you diagnose hydatid cyst, you will immediately start tablet albendazole. We will immediately start albendazole for the patients. So albendazole will be started. And under albendazole cover only, under cover of albendazole, under cover, usually after 2 weeks only we plan anything. So after giving 2 weeks of albendazole, after 2 weeks only we plan for any treatment. The treatments are now 2 types. Surgery is one treatment which was done in those days very commonly and which is now totally replaced by a new treatment known as PAR. So I'm going to discuss about these two. So let me discuss the conventional treatment first, that is surgery. So let us assume this is the hydatid cyst like this. So this is the ectocyst, this is middle laminated membrane, this is inner germinal layer with the cyst. Now what I'm going to do, what is the surgery commonly done is, so please observe this picture what I'm doing here. I will remove the ectocyst partially. I will remove the middle layer and inner layer fully. Now you see that is the partial pericystectomy. This procedure is known as partial pericystectomy. What I have left there? I have left some part of pericyst there itself. Why didn't I remove that? If I try to remove this, I will damage the hepatic vein or hepatic artery or major structures or biliary route will be damaged. So partial pericystectomy is the surgical treatment of choice nowadays. If you are planning for surgery, partial pericystectomy is a treatment of choice. Very rarely we will do hepatic resection. Very rare. They are all very rare. So we will do hepatic resection very rarely. After doing partial pericystectomy, always ensure, look for what? Inside the cavity, what you should look for? Look for biliary leak or biliary communication should be looked on. If there is a biliary communication present, we have to suture that. Please don't forget it. We have to suture that. So when you are doing a hydatid cyst operation, that surgical treatment of choice is partial pericystectomy. After doing partial pericystectomy, always look internally for any bile leak. If there is a bile leak, suture that leaks first. Suture that leak carefully. Please remember, you have to suture that leak carefully. Okay. And now coming to the new treatment, percutaneous aspiration, infusion, and reaspiration. This is a new treatment available now known as percutaneous aspiration, infusion, and reaspiration. So what we do in this procedure is we have to infuse some injections. What are the injections? So first what we should do in this procedure is, if this is a cyst, put a needle inside and aspirate. Whatever coming, aspirate. Then you infuse some agents. They are known as scolicidal agents. Again reaspirate. Again infuse. Again reaspirate. This is known as PAR. The best solution used for this is 20% hypertonic saline is the fluid of choice for this procedure. So the fluid of choice for this procedure is 20% hypertonic saline, 95% ethanol, mebendazole solution, 0.5% silver nitrate. So what are the various solutions used as scolicidal agents are 20% hypertonic saline, 95% ethanol, mebendazole, 0.5% silver nitrate are the various agents used. And what are the agents now contraindicated are? Previously we were using them. Povidone iodine is not to be used hereafter. Formalin is not to be used hereafter. So these are all not used nowadays. So please remember, hypertonic saline is one of the best solution. Best scolicidal agent is hypertonic saline. And PAR is indicated for swellings which are 6 cm like less than, cyst for less than 6 cm. PAR with a catheter should be left inside if the size of the is more than 6 cm. If it is more than 6 cm, we have to drain it and keep a catheter inside. And one more procedure is there known as PVAC, that is known as percutaneous evacuation of cyst content. Percutaneous evacuation of cyst content. That is known as percutaneous evacuation of cyst content is known as PVAC. So please don't forget the various procedures we are doing are PAR for less than 6 cm cyst, PAR catheter for more than 6 cm, PVAC for some cases which are having solid materials, we can evacuate the cyst content known as PVAC. So now comes the AIIMS question. What are all contraindications for PAR? High yield MCQ for AIIMS. Please don't forget, the last question in this topic is this. Contraindication of PAR. Number 1, if the cyst is superficially located, you should not do PAR because it can rupture inside. Number 1. Number 2, if there is a biliary communication, we should not use PAR because if you use the scolicidal agents, that will go inside the bile duct and can cause biliary sclerosis. Superficially located biliary communication Honeycomb cyst is a contraindication. What is the classification honeycomb cyst? It is coming under CE2. And number 4, dead cyst. It's also a contraindication. They will come under CE4 and 5. So you can see PAR is done only for CE1 and CE3. CE1 and CE3. CE2 it is contraindicated. CE4 and 5 it is contraindicated. And where else PAR is contraindicated? In lungs. Lungs hydatid. We cannot do PAR because they don't have the ectocyst. So PAR is contraindicated for superficially located cyst, presence of biliary communication, honeycomb cyst, dead cyst, and lungs. Okay, these are the places where PAR should not be advised. Otherwise, now the treatment of choice for hydatid cyst is PAR. So treatment of choice for hydatid cyst today is PAR, but there are certain contraindications. Don't forget those contraindications. Superficially located cyst, biliary communication, honeycomb cyst, dead cyst, lung hydatids are the place where the PAR is contraindicated. So I hope you understood the 3 infections. Let me show you the PowerPoint images. You should never miss to diagnose these cysts from the picture. So you can see this is a typical pyogenic abscess having multiple macro abscess. It is probably due to some cholangitis. You can see a tube being put in the bile duct. It is probably a cholangitis causing macro abscess. The most common organism is what? It is E. coli in world and Klebsiella in India. Okay, so this is a pyogenic abscess. Please don't forget. And this is an anchovy sauce color. You can see anchovy sauce pus. So what are the routes of infection? This is the most common complication you can see from the image itself. If it ruptures into the peritoneal cavity, either by laparoscopy or by laparotomy, we have to remove the abscess and put a drain. And various differences I told you between pyogenic and amoebic abscess. Please don't forget, and I want you to remember, the age group of pyogenic abscess is above 50 years, and for amoebic is young age. Amoebic is common in young drinking fellows. Okay, young drinking fellows will get amoebic abscess. Young drinking males, remember like that. Young alcoholic males will develop single large abscess known as amoebic abscess. Okay, so amoebic abscess is common in segment 7. Similarly, hydatid cyst is also common in segment 7. Both are common in segment 7. That is the most dependent part of portal vein. So therefore, segment 7 is the place of amoebic and hydatid. So the only liver function elevated in amoebic abscess is raised prothrombin time. So I want you to remember this CT scan, focus this CT scan few minutes. What is the diagnosis? This is a hypodense lesion having clustering of hypodense lesion with a peripheral rim enhancement. So this is pyogenic abscess. Please don't forget this image. And this is a single large abscess in segment 7 with a peripheral edema. So this is segment 7, peripheral edema, amoebic abscess. So this is a typical hydatid cyst. So you can see this is CE1 clear cyst, CE2 honeycomb cyst. This is CE3 having a water lily appearance. CE1 clear cyst, CE2 honeycomb, CE3 is water lily sign. And CE4 is partial calcification. You can see partial calcification, CE4. You can see a CE5 case here fully calcified, CE5. And this is a patient showing you multiple daughter cysts inside. So multiple daughter cysts looking like a honeycomb, CE2 hydatid cyst. So you should never make a mistake in diagnosing hydatid cyst. Okay. So please don't forget, when will you do PAR is less than 6 cm, PAR catheter above 6 cm. And these are the points where PAR is contraindicated. Please don't forget, PAR is contraindicated if there is a biliary communication, superficially located cyst, honeycomb cyst, dead cyst, lung hydatid are the places where PAR is contraindicated. Don't forget these points for your exam. So the 3 infections in liver you should not forget are pyogenic, amoebic and hydatid. High yield MCQ for your exams. All these images you must be ready to diagnose from the CT scan. Okay, thank you.